Hello, everybody. Thank you all for coming tonight. We are going to be discussing psoriatic arthritis. Um, I am a rheumatologist working at the Valley Medical Group based in Ridgewood, and psoriatic arthritis is something that we really do see a lot of. It's one of the major causes of rheumatic disease, together with others, and it's also it's been in the news a lot and very up and coming because a lot of very exciting developments and treatments have come forward, and we'll be touching upon those as well. So just by way of outline, we're going to sort of touch upon the basic aspects of this condition, of this disease. First of all, what is psoriatic arthritis? What are its features? How might you recognize it? What do we know about its epidemiology and its pathophysiology, by which we mean what do we understand about why it occurs and how it occurs? That's an ongoing project, of course, but quite interesting, and it's again it's led to other insights as well. How do you diagnose it if you think you have it? And what are some of the treatment options that we have? So these are some of the topics we'd like to touch upon. So what is psoriatic arthritis? And if you don't pay attention to anything else tonight, please pay attention to the cartoons. Just kidding. Okay, psoriatic arthritis. So it's a type of arthritis, and there are many kinds of arthritis. Arthritis essentially means a condition or disease of the joint. But it's a specific type of arthritis that leads to joint inflammation. What do we mean by joint inflammation? We mean pain and swelling. Not all entities that cause pain in the joint cause inflammation. Sometimes pain in the joint comes from trauma. Sometimes it comes from degeneration over time. But psoriatic arthritis is in the category of entities that cause inflammation. So it's a type of arthritis that causes inflammation characterized by joint pain, swelling, and stiffness. It can also affect the back, as we'll discuss, in the spine. And of course, it's called psoriatic arthritis because it's seen in people who have a chronic skin condition called psoriasis. So we will show some pictures of psoriasis. Most of you probably know what it looks like. But psoriasis is a very characteristic rash, also a chronic skin condition, although of the skin presenting as patches of thick red skin, often with silvery scale. So the thing about psoriatic arthritis is it's very interesting because it's very diverse in its presentation and in its different aspects. It's not just psoriasis plus arthritis equals psoriatic arthritis. There are other very key features of it. Sometimes these are the only features that are present. And when you're trying to wonder whether somebody has this, if you recognize one of these features, that will often lead you down the path to the diagnosis of psoriatic arthritis. And as we'll see, it makes a big difference as to whether you have this condition or another condition, because the treatments vary quite differently between the different causes of arthritis. So what are some of these features? Well, to begin with, looking at the diagram, there's psoriasis. So if you have psoriasis to begin with, that immediately sharpens your focus and makes you suspect psoriatic arthritis. I don't know if you can see my arrow here, but I'm trying to point to certain areas. Here's a pictorial depiction of psoriasis. Also, patients who have psoriatic arthritis and psoriasis have very characteristic nail changes. The nails are, after all, considered part of the skin. So we'll discuss this as well. But the presence of skin psoriasis, certain nail abnormalities are two of the key features. Then, of course, there's the presence of arthritis itself. So this will typically affect one of the joints. It could be a knee, it could be ankles, it could be hands. But the other thing that is interesting is that psoriatic arthritis has a particular predilection to the digits, the distal limbs, that is the fingers, the toes. You'll often get inflammation there, and you'll get a swelling of those areas. So dactylitis, which we'll discuss, means inflammation of the fingers. Dactyl means finger. And you also frequently in psoriatic arthritis get inflammation of the tendons and the ligaments. These are attachments. things that attach muscles to the bone, things that attach bone to the bone. Those are called ligaments. Those often get inflamed and affected by psoriatic arthritis. And that's quite a tricky thing to recognize sometimes. And how to distinguish between that and joint pain sometimes requires some acumen. So we've got the skin, we've got the nails, we've got joints, we've got digital involvement, we've got tendon involvement. And the final thing that you frequently see in psoriatic arthritis is involvement of the back and the spine. And we'll discuss this more. Okay. There are also less specific features of psoriatic arthritis, and this is something that is part of inflammatory conditions in general. So it's not just the presence, the specific presence of skin or of joint disease. There's also more non-specific things that people feel. For example, stiffness. If somebody who describes stiffness of the joints or of the back, you immediately begin to suspect that there's something inflammatory going on. And one of the key characteristics of psoriasis, of psoriatic arthritis, is that this is stiffness that worsens with immobility. Stiffness that worsens with immobility. It's worth repeating that phrase because it was drilled into us in training, but it's very characteristic. You know, most of the time, people who have joint pain, it gets worse the more you do things. You know, you would lift something, you would carry something, you've been on your feet too long, and that creates pain. But with psoriatic arthritis and the autoimmune inflammatory conditions that are in the same family, it's exactly the opposite. The less you do, the worse you feel. The more you sit, the more stiff you become. In fact, it tends to be worse in the morning when you've been lying all night, because something about immobility allows inflammation to flourish, and that's what causes the intense stiffness. And then, in fact, people say that they start feeling better when they move. So this stiffness with immobility, this morning stiffness, is a more non-specific feature of psoriatic arthritis that we often try to elicit when we speak to people. Fatigue is a very significant part of psoriatic arthritis. The fatigue is connected to the inflammation that people experience, and the fatigue often gets better when the inflammation is properly treated. And then there's other features that are sometimes hints. I'll just point this one out because this is very commonly seen with people who have psoriatic arthritis, is inflammation of the eye, redness and dimness of vision of the eye. That's known as uveitis. It's just something else to mention. Okay, so let's look at some images here. This is what psoriasis looks like. You know, I think if you had to describe it, you would describe it as a very well demarcated rash, with meaning to say a very fixed border of a red patch. There, it can come as patches, it can come as plaques. Sometimes it comes as little dots. But it's a raised lesion. It's red. It has a well-defined border, and it has a silvery scale overlying it. Here in the left upper corner, you see an example of psoriasis affecting the scalp. On the right side, you can see that it affects the knees. This is one of the areas where it often shows up. Here you see somebody's back with psoriasis. And now I want to point you to the nails. So we were speaking before about some of the very specific features of psoriatic arthritis, and one of them is nail involvement. So what is this nail involvement? So people with psoriatic arthritis have thickening of the nails. As you can see in the example in the right lower area, you have thickening of the nail, you have separation of the nail plate from the nail bed. And you also see this thing called pinning of the nails. It's as if you took like a pin and sort of made little dents and marks inside the nail. And it's interesting because this is so specific to psoriatic arthritis. There are very few things very few other things you see this with. Sometimes you'll have somebody who doesn't have any rash at all, who has no evidence of psoriasis, but they do have these characteristic nail features. And this might be the clue that we look for. This is one of the reasons why in rheumatology, we really are like Sherlock Holmes. We really have to look for every little detail we can find, because we, often to make our diagnoses, you really have to notice details that you otherwise may not. Okay, that's psoriasis. How about psoriatic arthritis? Well, some of the features are joint swelling. and tenderness. Again, we spoke about inflammation. We spoke about the fact that inflammation is a specific kind of arthritis. It's characterized by redness, by heat, and by swelling. And if you look at some of the pictures here, you can see that at the ends of the digits here, near the nails, you see these areas of swelling and redness and tenderness. This is something that you would often see in psoriatic arthritis. Also, in case you didn't notice, you can see the nail changes as well. Sorry. Okay, there's the back that we spoke about. So again, it's inflammatory back pain, worse with immobility, better with movement. If I were in a live room with you, I'd make you repeat that with me. Worse with immobility, better with movement, because this is really the key feature here. Now, the thing about the back pain is it's not just the regular back that can be involved. It can be the neck, it can be the mid back, it can be the low back, but it's also a specific area of the spine called the sacroiliac joint. So where is the sacroiliac joint? That's in the buttock. People with psoriatic arthritis who have spine involvements often have a lot of dull ache and inflammation in the buttock area. Again, that's worse when they've been sitting or lying around, better with movement, but that particular area of the spine is a neglected area of the spine. So, you know, when you go to your doctor and you have back pain, most physicians don't focus on that area because you really need special imaging studies to focus in on that area. Most people look at the lumbar area of the back, which is like the normal quote unquote low back that you think of, but people don't so much look at the buttock area, but the buttock area is what tends to be involved in psoriasis and psoriatic arthritis. Okay, back to dactylitis, okay? We mentioned that dactyl, means finger. Dactylitis means inflammation of the digit. And what's happening here is you can get a swelling of an entire digit. You can get swelling of a toe here. For example, in the picture on the right, you can get a swelling of a finger, example on the left. And the swelling is so diffuse and so widespread that you get the appearance of what they call, quote, sausage toe, sausage finger. Someone who has this feature, it's quite specific for psoriatic arthritis and makes you think about it. This is the other feature that we mentioned is tendinitis. Okay, so again, we mentioned that tendons are attachments, right? With psoriatic arthritis, you get inflammation of the tendon. Now, sometimes that's visible, as in this picture. Here you see you're looking behind somebody, you're looking at their heels. Then you can see the left heel is normal. You see a normal Achilles tendon, and the right heel is swollen and inflamed. And you can tell the difference just by comparing left to right. So sometimes it's quite obvious that somebody has a tendinitis, as in this picture, but sometimes it's not so obvious. You can get pain and inflammation of the tendon, and it's not necessarily always visible, but there are certain key areas where if people have pain there, that makes you think they have tendinitis. And again, that leads you down the path towards wondering whether they have something like psoriatic arthritis. What are some of the key areas of tendinitis? Well, there's the Achilles heel, like here. There is the soles of the feet, and of course that can present with plantar fasciitis, typically presenting as heel pain. There is pain in the elbows. People talk about tennis elbow, golfer's elbow. Sometimes you can get the symptoms of tennis elbow without playing tennis. If that happens, that means there's some inflammation of the tendon there, and that's something you would see with psoriatic arthritis, and also the knees. Okay, so, those are some of the features of psoriatic arthritis. We try to keep them all in mind. There have been many attempts to classify psoriatic arthritis. So let's say you have these features. Well, are there subtypes? Are there subtypes of psoriatic arthritis? So people who study this have tried to identify the subtypes. And that mainly has to do with which areas are involved and how many of them are involved. One way of classifying it is it mostly the distal ends? Is it mostly fingers and toes? Is it relatively few joints that are involved? Let's say less than 5. Is it many joints that are involved? That's called polyarthritis. Is it the type of psoriatic arthritis that presents with the most deformity? And that's the very rare and severe kind. Is it the kind that only affects the back? This is how you try to classify it. So again, looking at some pictures, this is the distal kind of psoriatic arthritis. Notice here you can see dactylitis on the hand on the right. You can see swelling of the finger. You see the nail changes. People may only present with involvement of fingers. This is what we call oligo. Oligo means few, and the definition of few is less than 5 joints. Now, the oligo type of psoriatic arthritis usually will be asymmetric. That means it'll just present on one side. A person will have, like, swelling of the knee on the left, or swelling of the ankle on the right, and then that's it. And you may wonder what it is. Well, why is the knee swollen? Was there an injury? Is it another kind of arthritis? But if you see this feature, this might be a feature of psoriatic arthritis. This is the poly type of psoriatic arthritis, in which you get involvement of many joints, and this one is symmetric. If this previous example is more asymmetric, this example is more symmetric, meaning you tend to get both hands involved, both elbows involved, both knees involved. This actually rather resembles rheumatoid arthritis. That's the other quintessential inflammatory arthritis that we take care of. How might you tell one from the other? Sometimes it's hard, but I guess with rheumatoid arthritis, you would not see psoriasis. And again, you would look for some of the other features we mentioned. This is a very rare type of psoriatic arthritis. It's called arthritis mutilans. This is what can happen when the deformities progress very aggressively without treatment. And then the spondylo form of psoriatic arthritis is in the back. And again, we keep emphasizing the back and the stiffness and the immobility factor, because there are some patients who only present with back pain and not other features. And again, can be confusing, because not everybody read the book, as they say. Not everybody presents in the typical way. So one way is to try to classify it based on whether there are many joints, few joints, distal joints, etc. The other is just to focus purely on, when you're trying to classify psoriatic arthritis, what area is involved? Is it just the back? Is it just the tendons? Is it just the digits? And usually they use this for research purposes when trying to recruit patients, but it's also useful in every day. If somebody is presenting with only inflammation of the tendons and nothing else, you begin to wonder, well, what's causing that? Could this be somebody with the beginnings of psoriatic arthritis? Just looking at percentages here, you see that far and away, one of the most common features of psoriatic arthritis is involvement of the nails. So don't forget to look at the nails. There is also involvement of the digits and the tendons, that's 30 to 50%. And involvement of the spine is actually not that common, it's 15%. Okay, how about epidemiology? What do we know? So psoriasis itself, first of all, is rather common. It affects 3% of the population. And that roughly equates to about 7 to 8 million people have psoriasis. Now, of those patients who have psoriasis, 20 to 30% will have psoriatic arthritis. By PSA, this abbreviation, I mean psoriatic arthritis. Psoriatic arthritis affects males and females equally. That's kind of interesting because it happens that in the autoimmune diseases, they tend to be much more female predominant. For some reason, the autoimmune diseases tend to affect women more than men, but psoriatic arthritis is kind of the same. The prevalence in the US now is anywhere from 6 to 25 per 10,000. And the typical time course of psoriatic arthritis is that the psoriasis will come first. 80% of the time, the psoriasis will precede the psoriatic arthritis. 15% of the time, however, the arthritis will come first. And you can imagine how confusing this is when there's no evidence of psoriasis at all. The average time between the appearance of skin involvement and joint involvement is about 10 years. So if you have psoriasis, you are at risk for psoriatic arthritis, but it does not mean that you will necessarily develop it. Okay. So what we need to remember about this is that in psoriatic arthritis, the arthritis can precede the psoriasis. We said that was 15% of the time. And in addition, sometimes the skin condition never occurs. So how else are we going to diagnose it if the psoriasis isn't there? That's something we'll mention. I also just want to mention that epidemiologically, psoriasis and psoriatic arthritis have associations with some of the morbidities that we see with other chronic disease, particularly with regard to cardiovascular risk factors. So patients who have psoriatic arthritis often also may have obesity, type 2 diabetes, and hypertension. These are, of course, features of what they now call the metabolic syndrome, which places you at risk for cardiovascular disease. But it's interesting that, you know, that there is a connection between the two, and that often when one has poorly controlled, let's say, diabetes or blood pressure, this can actually correlate with the severity of psoriatic arthritis. Like other chronic diseases, there's a significant disease burden with psoriatic arthritis. There is significant disability that comes with it. Studies have shown an association with the presence of psoriatic arthritis and work absenteeism, less work productivity. There's also a psychological burden that psoriatic arthritis has an association with depression. Okay, what can we say about the pathophysiology of psoriatic arthritis? I need a laugh track because how else do I know if you guys like my cartoons? Okay, so the short answer about the pathogenesis and pathophysiology of psoriatic arthritis is it's complicated. That's what I should have written on this slide. It's complicated because it really is. I don't think anyone can say with certainty what actually causes psoriatic arthritis, what leads to it, how to start it, how to stop it. You know, like a lot of the autoimmune diseases, it's a complex combination. There are genetic factors, there are environmental factors, and essentially the combination of these stressors and these provoking factors lead to basically a very intense immunologic reaction that persists. It's like somebody turns the on button on, and there is an immune reaction characterized by inflammation that continues and that is always there. Sometimes worse, sometimes better, but it's always present. And that leads to inflammation of the skin, and that is what we see with the psoriasis. And it can also lead to inflammation of the joints and tendons and back, and that's what leads to psoriatic arthritis. As far as the genetics go, it's highly genetic, much more so than other autoimmune diseases. 40% of patients with psoriasis or psoriatic arthritis will have first-degree relatives with the same. It's very important to elicit a family history. There have been genetic associations identified. Certain genes and certain alleles are likelier to be associated with psoriatic arthritis than with other conditions. There's a particular gene, part of the chromosome 6 called the MHC class 1 region, which has been known to immunologists for a very long time. And alleles, an allele is sort of a variant form of a gene called the HLA-B alleles, have a high association with psoriatic arthritis. Now, why do we mention that? It's interesting from the pathophysiologic perspective, but also there are now tests that you can do to see if somebody carries this gene. And if so, that may also make you suspect the presence of psoriatic arthritis more. Certain alleles are associated with different forms of the disease too. For example, there are certain HLA-B alleles that will make it likelier for you to present with skin disease as opposed to joint disease, or tendon disease as opposed to spine disease. What is the MHC gene? So we mentioned above that this part of there's a part of chromosome 6 that encodes the MHC protein. Just to whet your appetite a little bit for what the scientists do when they're trying to understand this. The MHC is a protein that's found on cells that helps present a foreign body. When your body gets an infection and it's processed and engulfed, it could be a virus, it could be a bacterium, it's engulfed by immune cells. It's kind of eaten up, chewed up, and presented on a protein. And that's called the MHC. It presents the part of the protein to the cells that will then get rid of it, in this case, the T cells. And that interaction is what then generates the response that teaches your body to remember an infection and to go after it next time and to clear it. So, and by the way, you know, this is very current and contemporary because, of course, this is what we're trying to understand with COVID, you know, and how COVID is affecting the body. And a lot of the immunologic techniques that have been used to develop the vaccines and the antibodies, the monoclonal antibodies against COVID, come from this same immunology that has been used to understand diseases like psoriasis and like psoriatic arthritis. So if you have a problem with the presentation of the foreign body, of this MHC that's supposed to be kind of like, it's kind of like the gift wrap that presents the gift of the infection. If there's a problem with it, then your own body begins to think that there's a foreign body there when there isn't. It's attracted to it because it sees that something's wrong there. It sees that it's not your normal cells presenting normal things, and it starts attacking it. And this is what we mean by an autoimmune process and an autoimmune disease. So if genetically patients with something like psoriasis or psoriatic arthritis have problems with the way their proteins appear on the cells, that will then generate a response to self. And again, make the body think that there's a problem there. And therefore create the so-called friendly fire, which generates the inflammatory immune response. So it's of course, it's much more complicated than I'm making it out to be, but it's kind of interesting because this is how they think about what's actually going down on the cellular level. There are environmental factors associated with psoriasis and psoriatic arthritis. They have found associations between the severity of the psoriasis itself and the severity of the arthritis. There are certain infections that they think have increased the likelihood of developing psoriasis. No one can prove that it comes from an infection because in many cases you can't identify the infection. But certain infections have definitely been associated with the appearance of psoriasis, like strep infection and like HIV infection. We mentioned obesity. There's a strong correlation of the presence of obesity and the presence of psoriatic arthritis. Trauma is a big factor as well. A joint that has had an injury is likelier to develop the signs of psoriatic arthritis, and skin that has had trauma to it, that an injury to it, is likelier to develop psoriasis over that injured, scarred skin. That's called the Keebner phenomenon. The other kind of interesting thing that they're trying to work out is a lot of patients with psoriasis and psoriatic arthritis have occult subclinical inflammation of the gut, of the GI tract. That when they study some of these patients, they find that they have inflammation in their GI tract and they didn't even know it. It's not like they have GI symptoms, but it's there. So it suggests that there is some inflammatory process that's really going on throughout the body. It's not just limited to the skin, and it's not even just limited to the joints. Okay, so, well, if you're trying to put together a story of how psoriasis and psoriatic arthritis happens, there is some stress that happens. We may recognize it, we may not recognize it in a host that is genetically predisposed to developing something like psoriasis or psoriatic arthritis. There's the so-called insult, and then there's the response to it. And then this starts generating that immune response that we spoke about. There is, and this they know a lot about because they study the tissues, they study the skin, they study the cells, they study the fluid of the joints that are involved in psoriatic arthritis, and they see large number of immune cells, they see large number of molecules. And I want to point out one thing in particular, which is very significant, and this is called cytokines. I don't know if you've heard of cytokines. It's often, you often see it in the news or you see it on the commercials for the medications. Cytokines are proteins. They are kind of like, if you want a way to think about it, it's the on switch. Think about it like the on switch. What is the on switch that generates inflammation in the body? In something like psoriatic arthritis, and this is a cytokine. It's a protein. It's released by certain immune cells. Once they're released, they then stimulate other immune cells. But if you're trying to find, like, going back and back and back in the process that generates the inflammation in the skin, the inflammation in the joints, what is the original sin? What is the original on button that started the whole thing? They have traced this back to cytokines. Now, why is it important to think about cytokines, right? There's so much else that's going on in psoriasis and psoriatic arthritis. Well, the reason is because this has been the key to the development of the treatments for psoriasis and psoriatic arthritis. And of course, not just in this condition, but in many conditions like RA, rheumatoid arthritis as well. By identifying which cytokines were key in setting off the inflammation, they then developed medications and drugs that blocked and attacked and stopped these cytokines. When the cytokines are no longer there, the inflammation shuts down. And this has been nothing short of revolutionary, because in the past 15 to 20 years, they've developed these medicines that have made huge differences in the lives of people who have psoriasis and psoriatic arthritis. These are certainly medications that didn't exist 30 years ago. So we'll talk more about that. Just to point out quickly, don't worry about the crazy cartoon, but the three most important cytokines that they've identified that have led directly to treatments are TNF, and there's something called IL-17 and IL-12/23. Not that there may or may not be a test on this at the end, but not that you have to memorize it. But just to know, when you hear about medications in the news or in the commercials like Enbrel, Humira, Remicade, Taltz, these are medicines that usually antagonize or try to stop or block one of these cytokines. So this has also been a key finding in the pathogenesis of psoriasis and psoriatic arthritis. Okay. Well, how do we diagnose it? So we use our traditional tools to make a diagnosis. And again, because psoriatic arthritis and psoriasis is often not obvious, we have to use every clue we can. We need to get data from every way we have of evaluating somebody and evaluating their information, and then often make a best guess. When it's obvious, it's obvious. You know, when it looks like the pictures I showed you and the symptoms that I described, you know what you're dealing with. But very often it's not that. And one of the reasons for that is because sometimes the different features of psoriasis and psoriatic arthritis only show up one at a time. You might just get somebody with a tendinitis, and other things won't happen until another couple of years. So it's very hard to call it something before you've seen the full picture, before you have the benefit of time. And that's why close follow-up with a physician and close attention to your symptoms is so important. But you can get clues, okay? So somebody who has symptoms of arthritis and has a history of psoriasis, of course, that will be much easier to think about. Family history of psoriasis, even if you don't have psoriasis. Of course, we look for the characteristic features we talked about, including joint pain, swelling, back pain, digital swelling. The examination is very important. So what does the skin look like? Now, of course, if you see psoriasis, that's great. As I said, sometimes those psoriasis is very subtle and very hard to find. It can be behind the ear. It can be near the belly button, or it can just be a single small change in the nail. So you really have to be like Sherlock and Watson sometimes to try to see what's going on. Once I was speaking to a patient who had some arthritic symptoms, and it was really hard to figure out what was going on with him. It wasn't quite fitting a pattern, and yet I knew something was off. And so I said to him, okay, I'm listening to what you're saying. I'm trying to figure it out. Have you ever had any kind of rash? I couldn't see any rash when I looked at him. And then he looked back at me, and he had hair over his forehead, and he said, oh, do you mean like this? And then I suddenly saw the psoriatic lesion, and I said, I know what's going on now. So you have to look for these things. You have to look for them. Laboratory studies. Okay, I'm showing you this slide just to make the point that there is no test that diagnoses psoriatic arthritis. In that way, it's very different from other conditions that we see, for example, rheumatoid arthritis or lupus or other autoimmune diseases in which you can actually make a diagnosis based on a blood test. There is no such blood test. So when you suspect psoriatic arthritis and you do not find the presence of rheumatoid test or the blood tests that do help you with things, you begin to wonder if it really is psoriatic arthritis. Nevertheless, there are things you can look for in the blood, and we do these when people are in the office. You look for inflammation. You do this genetic test that we spoke about before, the HLA-B27. The other thing that really helps us, I have to mention, of course, is imaging. You know, in rheumatology, we're very interested in the joints, in the structure and alignment of the joints. So we use x-rays because the appearance of the joints on x-ray will often give us a lot of clues. There are certain ways that psoriasis looks on a hand x-ray. There are certain ways that other kinds of arthritis look on an x-ray. Some of the features are what are called erosions. I don't know how well you can see this, but erosion kind of means like a small bite out of the bone, a small bite out of the joint. The loss of bone that they call erosion is something you see in psoriatic arthritis. Another thing you see is the formation of bone. So you lose bone and you form bone. And if you're used to looking at x-rays like these, it can kind of help you make the diagnosis. These are examples of bone formation. So the interesting thing about psoriatic arthritis is when you get inflammation of tendons and ligaments, like we said before, of attachments, they sometimes change into bone. It's kind of like they scar and they calcify, and then suddenly you have a bone where a bone wasn't there before. So for example, if you look at the left, this is somebody's heel. If you see the back end of the heel, there's this triangular bone jutting out. That is a bone formation that is the result of inflammation of the tendon that occurred there, probably for quite some time. Let's look at the figure on the right just to give you a flavor for this. And these are things, by the way, that happen over many years. They don't happen immediately. You have somebody's spine here with the vertebral bodies, the little blocks, one on top of the other. If you look on the right side, you see this crescent shape here. Almost looks like a half moon. That used to be a ligament that attached an attachment between the vertebral bodies, and it became bone. That is also a very, very key feature of psoriatic arthritis. So again, I just mentioned this to point out that when you're trying to figure out what's going on, you really have to look at all the information. And sometimes you won't have so much information from blood work or even from an exam or even from history. But if you see certain things on x-ray, you'll suddenly get the idea. And I also want to mention, of course, that other studies, other imaging studies that are very helpful are ultrasound and MRI. They can tell us tons of information that are quite useful. Okay, so again, this reminds us of the 5 domains when you're making a diagnosis of psoriasis. You look for these 5 features. Is psoriasis present? Are the joints involved? Is the spine involved? Are the tendons and fingers involved? These are known as the Casper criteria. I only mention this because it's interesting to sometimes see how do the guys in the big league do it. You know, those universities or those pharmaceutical companies that do large-scale studies with thousands of patients, how do they know when they're dealing with psoriatic arthritis? It's not an easy thing to diagnose. So every patient who's enrolled in a study or in a clinical trial has to fulfill the Casper criteria. And this is just an example of what they look for. It's based on the presence of psoriasis, it's based on the presence of arthritis, but they also ask interesting questions. And if you get enough of these questions right, you qualify, and then they're comfortable that you really have psoriatic arthritis and that you can enter the trial. One of them is the family history of psoriasis. So again, you could not have psoriasis yourself, but if you have a family history of psoriasis, that already puts you into that category. A negative test for rheumatoid arthritis, right? That it's not even that you have one thing, it's that you don't have another, and other features as well. Okay. Remember that, you know, just because it might be psoriatic arthritis doesn't mean it has to be, and a lot of things can resemble it, especially when the skin condition is not there. These are the most commonly seen entities that can present like psoriasis and psoriatic arthritis, but that are quite different for various reasons. Another time, if we have another talk, we can go through these. How about treatment now? This is a typical day in my office. But don't be intimidated. Okay, there's a general approach to treatment, what I call the more holistic approach to treatment of psoriatic arthritis. There is how we treat milder symptoms and how we treat more moderate to severe symptoms. And it's a continuum. And sometimes you have to move from one to the other. Okay, so, the holistic approach is kind of what you'd expect. Because psoriasis has an association with obesity, weight loss is key. That really helps people. Sometimes just losing weight and maintaining a healthy lifestyle of diet, controlling blood sugar, controlling blood pressure, will eliminate a lot of inflammation. And you may not even need medications, which is really the ideal scenario. Exercise, of course, definitely helps, because as we said, this is a condition in which you feel worse when you're not mobile. So being mobile will often help. But what if you're trying all the holistic lifestyle modification things and it's not quite helping? So the first step is if it's mild, quote unquote, meaning there are relatively few joints involved, it's not so severe, it's not something that necessarily impairs you, not something that wakes you up at night, right? Or in the early morning, you can use anti-inflammatory medications. Just what you'd expect. There's two categories of the anti-inflammatories, the NSAIDs, the non-selective and the selective. Non-selective is what you might get over the counter or what might be prescribed. I want to point out that the selective anti-inflammatories like Celebrex they're particularly used because they spare the stomach. They've been engineered so that they're not as likely to cause ulcer disease the way the others might. The other thing I would mention is that if you have relatively few, perhaps one or two joints that are involved in psoriatic arthritis, you don't necessarily want to commit yourself to a systemic medicine that you have to stay on. Sometimes we give steroid injections. It's cortisone. It's the administration of cortisone, into let's say a knee or a shoulder. Sometimes that's quite helpful and can bide time and can help you avoid other medicines. Okay, but what if it really is moderate or severe? Now, for it to be moderate or severe, it doesn't just mean that you have to have 5 or 6 joints involved or many joints. Sometimes a single joint can be very severe. If you're someone who has chronic inflammation of the knee and Motrin is not cutting it, that means it's time to move on. That means it's time to see what other medications are available. And there's a lot of really excellent medications that are relatively safe and that have made a big difference. So the two categories are the traditional DMARDs and the biologic DMARDs. What does DMARDs mean? Disease-modifying anti-rheumatic drugs. These are immunosuppressive medications. You may have heard of them in the news now. Now they talk about them a lot with regard to the vaccine and with regard to COVID protection and safety. Immunosuppressive is DMARD. It's the same thing. The way they work essentially is by lowering the potency of the immune system and holding it back. So I just wanted to mention some names of the treatments that we use. The traditional DMARDs are pills. Methotrexate is something that's been used for a long time. It's also used in rheumatoid arthritis. In fact, some of the same medicines that are used for rheumatoid arthritis are used for psoriatic arthritis. These are quite effective. They're not the most powerful we have, but on the other hand, they're not the most dangerous we have as far as side effects. So they're somewhere in the middle. The thing about them is they do need to be monitored. So you need to check blood work when you're on them. Sometimes they have some side effects, but that depends on the person and depends on the dose. But they're quite effective. They're easy to get. They're usually approved by insurance. And they're helpful for both psoriasis and psoriatic arthritis. The one at the bottom, Otezla, is a relatively recent one that's been approved as well. I put it more in the family of the moderate range medicines because it's not as potent as the other ones. There goes my slide again, just to point out that what we talked about before with regard to cytokines and that key immunologic factor that's thought to stimulate the immune system has been the source of our main therapies, of the most effective therapies that we have. So these are called the biologics, and all of them work by antagonizing the cytokines, trying to stop them, trying to turn them off. And they've been remarkably successful. So there's the TNF inhibitors, and Phil Mickelson, if you've seen those commercials, I think he's an Enbrel guy, and these are the oldest ones we have. They're already 20 years old plus. They work extremely well against psoriasis, against psoriatic arthritis, against spine disease, against inflammation of the tendons and inflammation of the digits. They really work with everything. They're not 100%. Sometimes one needs additional therapies or one needs to switch from one to the other. One can develop resistance after a while, but they're really game changers and much more effective. I'll just mention some names of things you might have seen out there as well. There's something called Stelara, which is an injection. Cosentyx and Taltz are new kids on the block. They're constantly in the commercials. It shows the power of the pharmaceutical company to advertise, but they're quite good. They're really good alternatives to the TNF inhibitors, and that is to Enbrel and Humira. If let's say you're taking one of these medicines and they're not quite working, or you've developed an intolerance to it, it's really nice that you have all these other options to go to as well. Some of the newer things, the very newer things, include what we call the JAK inhibitors, Xeljanz and Rinvoq. You may have heard these names. These are pills. So this is a very interesting new concept that they have, that they work as well as the injections. I should mention, by the way, that most of the biologic therapies are injections. They're shots or they're infusions. Almost none of them are pills, except for these two. These two are actually pills that work as well. However, there's been some negative press recently about these agents, Xeljanz and Rinvoq, because they found that a very slight increase in patients were found to have developed heart complications or blood clots or cancer. That was seen in a very, very tiny increase in patients who are on these medicines. They don't know yet whether it's really caused by the medicine or whether they're patients who it might have happened to anyway, but it was enough for the FDA to give a black box warning to these medications. So nowadays, the pills, they used to be very attractive to us because most people would prefer a pill to a shot, but nowadays the pills are second line. So you don't start with them. You start, if you need a medicine of this potency, you start with an injection. The newest kids on the block are the IL-23 inhibitors. This is the last category, the most recent, I should say, category of biologics. Tremfya and Skyrizi, those are their names. They're really, really superb. Even the biologic therapy, which itself was a very cool concept, they've really narrowed it down to quite a finesse, with some of these medicines. And they think that these medicines, and I say this preliminarily because they're still relatively new, but are really considered the single best agents for psoriasis that there are. In fact, I'm hearing more and more that the dermatologists are not, they're not pass and go, they're not collecting $200, they're going straight for these medicines. These are the ones that they all prefer to prescribe first off, because they're so effective and they're so rapidly active. Now, how are they for psoriatic arthritis? They're about equivalent to the others. I don't think they've shown superiority in psoriatic arthritis, but for the psoriasis, they're extraordinary. So you may want to remember them, Tremfya and Skyrizi. Okay, so in conclusion, and I'm sorry if I went a bit over here, we see we've had an introduction to psoriatic arthritis. We see it's quite complex. It's not just psoriasis plus arthritis. It's many different manifestations that involve the skin, the joint, the spine, the tendons, but it's a very sort of characteristic picture. And if you've seen it enough, you can recognize it. It's very complex, and no one can claim to understand exactly why and how it occurs, but we've learned enough about it, about its genetic features, environmental features, and immunologic qualities, that this has enabled us to develop certain medications, which are really, really exciting and really, really effective, and we really think relatively safe thus far. So it's a good time to be studying this condition and hopefully to be offering help with this. So thank you very much for your attention.
Thank you so much, Dr. Zaider. And I think I can speak for the group in saying that we did pay attention to the cartoons, the gargantuan needle that you had. We're going to go over some questions.
Great.
So the first question is bursitis a common part of psoriatic arthritis?
Yes, absolutely. What bursitis is the bursal sac is sort of the cushion that lies beneath the tendon when the tendon is attaching. So because we said that psoriatic arthritis is characterized by inflammation of the tendons, wherever there are tendons, there's bursae, there's a bursa. So the answer is yes, bursitis is something you often see with psoriatic arthritis as well.
Thank you. And the next question, I think you have answered this one. If has arthritis, would they have psoriasis too? I think you can go again.
Well, yes, it's worth making note of. I mean, if you have psoriasis, they say there's about a 30% chance of developing the arthritis with it. So it's a minority of the cases. If you have, but 15% of the psoriatic arthritis patients don't have psoriasis at all. So that those are like the figures that they have now. But yes, you can see it the other way around as well. If you have, features of the arthritis, you can eventually develop a psoriasis too.
Right. And then this other questions about does having an infection in childhood of strep lead to onset of adult PSA?
Right. Very interesting question. And it's actually in the pediatric population that they have hypothesized that strep infection may have a role. It's one of those provoking factors that can lead to psoriasis, because I think they saw in kids that kids who had very bad strep infections, some of them actually developed psoriasis or psoriatic lesions. And they also noticed that in certain subpopulations of patients who happened to have psoriasis, again, mostly pediatric, when they had tonsillectomies, they got better. The psoriasis went away. Now, that's not true across the board. Clearly, it's more complex and there are more things at play, but that made them think that there's a connection there.
Great, thank you. And do medications reverse or just slow down the progress of the condition?
Well, that's an excellent question. Some people think that if you intervene early enough, you can reset the immunologic cascade, the immunologic soup that's going on there, and that you may not need to be on these medications for too long a period. So there are studies now trying to understand that if you start the medications much earlier than you would have, could you then get off of them faster and stay off of them? In general, though, I think in the majority of the cases, it's chronic. It's hard to come off of the medications because most of the time it relapses. It does come back. Now, having said that, there are some people who still, when they're doing quite well, they manage to be able to take the medications less often. So, for example, if you were used to taking a biologic injection medicine that was given every month, and you've been doing well for a number of years, then we would give it every 2 months or every 3 months. And sometimes that really does suffice. So it's a bit of the mystery of the condition, of why in some people it really can be much, much milder after time, and other people it just persists.
Interesting. I guess it's just the nature of an autoimmune disease.
Right, right.
So we have a question about methotrexate. How long before and after getting the COVID vaccine or booster should they be off methotrexate? But it could probably apply to any biologic.
Right, absolutely. This is a great thing to mention, and that the information about it is changing. It used to be that we had everybody stop all immunosuppression for a number of weeks before and a number of weeks after getting the vaccine. But I think the current recommendation is if you're going to get a vaccine or a booster, you should stop the methotrexate for just 1 week after. And that actually suffices. For a lot of the other medications, for the TNF medications like Humira, Enbrel, Remicade, or even the medicines like Taltz or Cosentyx, which you may have heard about, it's interesting. They don't think that affects humoral immunity. In other words, it doesn't necessarily affect antibody production. Because a lot of these medicines don't affect antibody production, you don't even have to stop them when you're getting vaccines or boosters against COVID. Methotrexate is different, though. Methotrexate is kind of smothers the immune system, and that includes B cells that make the antibodies. So with methotrexate, you have to kind of stay away from it when you're trying to develop a good response to the boosters and vaccines.
I see. And would disqualify them being on these biologics, would disqualify them for getting the second boosters now, I believe.
Yes, yes, absolutely, absolutely. So even though it's interesting, even though they don't interfere with your response to the booster, they qualify. I mean, somebody who's on one of these medicines is considered immunosuppressed or on immunosuppressive medication. And the current recommendation, as I understand it, is to actually get a fourth shot now for those patients who are on such medicines, like the ones we've been talking about.
Yes, yes, thank you. Another question, can tendinopathy be anywhere? Hands, wrists?
Yes, yes, absolutely, because the tendons are everywhere. But having said that, there are certain areas where they're much more common, and that probably has to do with the way we walk and use our hands and use our arms and weight bear and so forth. So although there are tendons everywhere in the shoulders, in the elbows, in the hips, in the ankles, these are not necessarily always the most commonly involved. The most commonly involved tendons are the heel and the sole of the foot, the elbows, and the knees. But tendons are everywhere because the definition of a tendon is just an attachment of the muscle to the bone. So they're everywhere.
Perfect. There's a question about a person here not responding to multiple biologics, both self-injection and infusion therapy. Is this common? Should they be concerned? I guess, like, what's the time frame of observation?
Right, right. So excellent question. In general, when somebody starts one of these medicines, you have to give yourself at least 3 to 4 months because it takes a while to be loaded into the system. It takes a while to work. It takes a while to build up its levels. And then in some cases, you also have to realize that the doses that are recommended by the manufacturer aren't high enough. For example, for Cosentyx, which is a monthly injection for psoriasis and psoriatic arthritis, there are 2 doses, so the initial dose may take 3 or 4 months to act. And if that's not working, we then double it. One of the problems about these medicines is that, the companies that produce them kind of had to make a best guess as to what dose would fit all. But it's really not like that in real life. In other words, there's only one dose of Humira you can get, no matter what your size and BMI and height and weight is. But that almost doesn't make sense because you can certainly see how some people might need a higher dose than someone else. It could be based on their size. It could be based on the severity of their disease. So that's one of the problems with these medicines, that, we don't have the possibility of titrating their dose, of increasing it or decreasing it. Like, what you get is what you get, But anyway, having said that, if you give these medicines a trial of 3 to 4 months at a time, that is usually an adequate trial.
And do you usually do a combination sometimes?
Yes. Well, what you can do is what we often do is we combine the biologic DMARDs with the more moderate DMARDs. In other words, medicines like Humira and Enbrel can be combined with methotrexate and Otezla. But what we never do is I never say never, but we usually don't combine the biologic medicines.
Right.
So in other words, you would not give Enbrel and Taltz or Humira and Cosentyx or something. They think that's too dangerous. It suppresses the immune system too much.
Too much. There's a question about whether it's possible to develop antibodies to biologics and after how long. So maybe they mean resistance or,
Yes, that's absolutely something that we see. It depends on which biologic medicine you're talking about. It's been very well documented in Remicade. Remicade is an infusion medicine that they give for a lot of things. They give it for rheumatoid arthritis, for Crohn's disease, and they also give it for psoriasis, as it happens in psoriatic arthritis. But they noticed that in a certain percentage of patients, it doesn't work anymore. And then they noticed that in those patients in whom it doesn't work, they have high levels of anti-drug antibodies. Now, it could be that this is particularly seen in something like Remicade, because Remicade is developed from mice. It's what they call chimeric. It's developed from mouse cells. That's not necessarily true of the other biologics. They're synthetic, so maybe we're less likely to develop resistance or reactions to them. However, I think this is a really good point. And I think when something's not working, you have to wonder, has the body developed a resistance to it? Right now, we don't have the tests to identify, for example, whether somebody has Enbrel resistance, or Xeljanz resistance. The technology is probably there, but it hasn't been made available or commercial.
Thank you. And I think you mentioned this earlier. Is there a possibility that you can go into remission? And if so, what does that mean?
Right. There is a possibility. I think that they have found that of those patients, who have been on biologic therapy for a certain amount of time, actually something like 20% of them can go into remission. And what remission means is that, after you've been on medicine for a good year or so, you can start to wean it and you can start to get it less, you can take it less frequently. And then eventually you can actually come off of it entirely and not necessarily have to go back on. So I think what I said before was a slightly more pessimistic version of that, but remission is possible. It's not the most common scenario, and it doesn't necessarily happen so fast, but it is possible.
Perfect. You had mentioned during your talk about lifestyle changes that could possibly help. So there's a few questions about it. Any
Sure.
diet to either diet, food advice, or weight loss, or any food items to avoid?
Right. That's a great question. And that sphere is not studied as much as it should be. I'll say that right off the bat. We're so busy kind of studying the medications and the trials involved with them and their effects and so forth, that we don't pay enough attention to the big picture, which is, what's going on with lifestyle. As far as, for example, nutrition supplements, there have been studies that have suggested that vitamin D is very beneficial for psoriasis and for psoriatic arthritis. It's a good vitamin to take. The truth is, it's good for a lot of reasons, for a lot of other things. But vitamin D is one of those things that they think can be beneficial. Fish oil, they say, can be beneficial as well. As far as diets, because there's an association of worsening of psoriasis and psoriatic arthritis with conditions such as obesity, blood pressure, diabetes, it stands to reason that if you can avoid high fat, high sugary, high carb foods, that's probably very beneficial. Sometimes there are other things that generate inflammation in people, like gluten or like dairy. If someone is lactose intolerant, and sometimes you have to discover that. And if you're one of those people and you eliminate that from your diet, you suddenly start feeling a lot better. But I get the sense that for people who cut back on sugar and on carbs, which we all love so much, but if you can actually cut back, that's quite beneficial for inflammatory conditions like psoriasis and psoriatic arthritis.
And all the other comorbidities, chronic conditions that you mentioned that come with inflammatory diseases.
Absolutely.
There's a question about if psoriatic arthritis cause uncontrollable constant itching in certain areas like forearms. I would think it's probably where there's no rash present.
Well, the psoriatic lesions themselves are very uncomfortable and very itchy. If you're asking whether one can get itching, pruritus, what they call, without obvious psoriasis present, not sure how common that is, or whether that can be attributed to psoriasis. Usually it's due to something else. It could be due to a medication, or perhaps another, something going on with the blood tests and with your inner metabolism.
I see. When would you recommend genetic testing?
Right, that's a great question. Well, most of the genetic tests have not really come into commercial use because, the very same alleles that are associated with psoriasis and psoriatic arthritis are also seen in normal people sometimes. People, I say normal, what I mean is people who don't have psoriatic arthritis. But there's one particular genetic test that is quite helpful, and you can order this. It's called the HLA-B27. People who have this and who have features of psoriatic arthritis are much more likely to actually have the inflammatory form of it, and also the form that particularly causes spine disease. But beyond that, there is not now, a sort of genetic panel that we routinely order in people. We're hoping to get something like that someday soon, but it's not come into widespread use.
Right. I think one other question we have is when does a person need to see a rheumatologist? A lot of people, they have this pain and that pain, this rash and that rash, and it could go on and on for years, but they don't know when they should reach out for rheumatology.
That's a great question. Anytime, anywhere. That's what I say. No, I think
always
that
need Sherlock Holmes.
Right. Well, look, it's good to be educated about the rheumatic conditions, because there are certain conditions that only rheumatologists deal with. And these are the arthritic conditions, osteoarthritis, the inflammatory autoimmune conditions like rheumatoid arthritis or psoriatic arthritis. And then sometimes there are things that are in between, and this is actually more common than less common. Sometimes we have unexplained symptoms. We don't know whether something is just going to pass, or whether it means that, there is an inflammatory process beginning. So I think when it's not clear from your primary physician, from one of your other specialists, from your dermatologist, about why you have a certain feature, then I think it's appropriate, to at least, see if there's something rheumatic going on, because, often the tests that we do are not the tests that other people do. And we can at least try to get a sense of whether it's in our category. And because we see so many things that are often unusual, are often can't be characterized, or often belong to other specialties, but sort of show up at our door first, we often know who to refer them to next. So I think it's a worthwhile thing to do if you're not sure of what's going on. But in general, that there are certain conditions that belong in rheumatology. As they say, you'd be in the right office.
Right. Perfect. Thank you so much, Dr. Zaider. That was wonderful. It was a great informative presentation. I think